Hello, I'm Dr. Thais Tenori from the University of Mississippi Medical Center, and I would like to discuss and present questions on end-of-life issues for you to contemplate. What I would like us to emphasize during this session is the different levels of care that are available at the end of life, to consider the skills you wish to develop on discussion of end of life with patients, to recognize common symptoms and concerns that occur during this time period, and to also consider how this affects you when your patients are reaching the end of life. Part of being in primary care, particularly family medicine, since that's what I know best, is helping patients approach and deal with the end of life. As the population in this country is growing older and older, these situations will present themselves much more often during your practice than you want to consider at this point in time. I feel that part of being a primary care provider is also recognizing when this is the process that the patient is approaching and helping the patient be prepared to reach this optimally. Our goals in taking care of patients are treatment and recovery to increase health and boost learning, and this is what most of the office visits that we have with our patients incorporate. They have an acute complaint, we deal with it, we make it go away. We do preventive screening, we try to keep them in the best health possible. When health care turns into palliative care, what we are doing is trying to relieve symptoms and prevent suffering in a patient for a condition that is not going to go away or disappear. This is end-of-life care. Here's a case of a 93-year-old woman who has had a stroke in the past. She is cared for at home by family members. She is bedridden, but they have taken very good care of her in that she has no skin breakdown. They do help her sit in a chair part of the day. But when they bring her into the hospital this time, they notice that she is not alert as she used to be, and this has been going on for about 2 weeks. She has not been walking in 18 months since her stroke, so she has just been from bed to chair and back. Her eating has decreased, her appetite has decreased, and she's only taking in a few bites daily. She was talking with them some, but now is only nodding her head to questions. On physical exam, her vital signs look good. She's a very thin elderly woman, and she's not in any distress. Occasionally, she will follow simple commands while you're examining her, but she is not making any attempt to respond verbally. She exhibits temporal wasting. Her mucous membranes are dry. Her neck is supple, but it's very thin. Her lungs have no increased respiratory effort, but normal lung sounds are present. The heart is a regular rhythm. There's a systolic murmur in the upper sternal borders that radiates to the neck more on the left than the right. Her abdomen is scaphoid. There's no masses or tenderness present, and her extremities are very thin. She moves them spontaneously. She does grip when you ask her to, but it's about a 3 to a 4 out of 5. And the other commands that you are trying to give, she does not follow for you to assess her more thoroughly on her strength. Her laboratory work is obtained. She does have a urinary tract infection. Her leukocytes are 2+ and nitrites are 1+. She is anemic with a crit of 26. So what else do you want to know about this woman? You have a very elderly woman who has decreased responsiveness. She has increased lethargy. She does have a urinary tract infection. So what's going on? These can be presentations for an infection in an elderly person. So we've got a urinary tract infection, but also we want to know this is a 93-year-old woman. What if she goes south? What if she does not improve? What if she gets worse? How much do we want to do on a 93-year-old woman whose life is spent in bed? What were her wishes when she could express them for how much care she wanted at this point in her life, at the end of her life? The best time to find out about this is before you need it. As I said, palliative care would treat her symptoms, but not prolong her life. And is this what she wanted to do, or does she want us to treat her vigorously, bring her back to the state of health that she was in for the last year and a half, and see what happens from there? In family medicine and in primary care, we are able to establish a relationship with our patients over time. And during this time that we are taking care of our patients and getting to know them, we need to become comfortable in asking them, what is it you want for your care at the end of your life, regardless of what's going on? These are the advanced directives. These are the instructions that the patient can give while they are able on how much they want done. Do they want aggressive care? Are they going to fight for cure and recovery? Do they want their life prolonged? Do they want the natural process of dying to occur without any interference, but be made comfortable during this time? Waiting until the end to get this information can be very stressful to the physician as well as to the family, because everybody has an idea of what they want done, and oftentimes the patient is no longer able to give us their wishes. The living will is one mechanism that is used to deliver these instructions. Other legal documents or outlines can be found that can be used for this. And in your practice, you need to figure out what works best for you. If the patients don't have a way to express this or want instructions or guidelines, you can come up with a selection that will allow them to outline what they want done. The other thing you want to be sure to tell your patients is, if you have written down who makes your medical decisions and what you want done, particularly in certain events at the end of your life, please give the physician a copy. And if there's only one hospital this patient uses, it's okay to send a copy to the hospital and at least have it in their record so that when you need it, it's available to you. Advanced directives are going to address the goals or focus of the care that the patient wants, where they want to be cared for, and how much treatment is allowed. Is their goal a cure of their disease, to prolong their life, or to keep them comfortable? What specific types of treatments and therapies does the patient want? And these can be outlined specifically. It doesn't just have to be a, I want to be resuscitated, I don't want to be resuscitated type of answer, because those really don't give you all the information you need. Does the patient want blood transfusions? Would they want surgery done? Do they want to be on a ventilator? Do they want feeding tubes? Do they want every infection treated with antibiotics? There's an old saying that pneumonia was the old man's friend. And way back, we didn't have very many antibiotic choices, and when a patient got pneumonia, oftentimes it led to their ultimate death. Where do you want to be taken care of? If you want to go home, have home health, have hospice care. If you want to be in an inpatient hospice center for the end of life, do you want to go back and forth to the hospital and receive treatments and therapies that would prolong your life here on this earth? Or do you want to be taken care of in a nursing home? Do you want to be where professionals are delivering all the health care, or do you feel like your family members are up to delivering the care that you want to have? These are questions that you need to get the answers from in an organized fashion over a period of time as you get to know your patients. Not only are the physical needs important in the patient's care, but the emotional needs, social needs, and spiritual needs of the patient, as well as of the family, should be addressed during this time period. And as the family physician, you not only are helping the patient with end of life, you're helping all the relatives of the family with the end of this patient's life as part of your caring plan. Hospice care addresses patients who no longer are seeking a cure for their illness. The definition is that the patient is not expected to live longer than 6 months. This should be expressed to the family and to the patient if possible as they are signing up for hospice care. You need to be aware of some agencies that may sign patients up that you haven't referred, and you get orders to sign on this patient and you don't know that the patient is not expected to live for 6 months. You call the patient and they have been solicited to sign up for this care. And this is not most of the healthcare agencies, but occasionally it does happen. So you need to be sure that you have referred the patient to this hospice center before you sign the orders. Hospice care focuses on quality rather than the quantity of life. Patients who outlive their 6 months aren't rejected from hospice care. But if they live for more than a couple of years, they probably will be removed from hospice care. The desire is for the patient to have each day lived in comfort with decreased pain and also in the presence of people who care for them. There is extensive family support during the process of dying and then in follow-up bereavement care for the family members after the patient is gone that is supplied by hospice. Hospice care is also a financial consideration for the patients in that the counseling, the support, some respite care for the family where someone can stay with the patient while the family runs to the store or just has a short break from patient care are also provided during this. If on hospice care the patient elects to go back to the hospital, they have to be discharged so that the financial arrangements with Medicare or the insurance that the patient carries are dealt with by the hospital, and then they can be readmitted to hospice care. During the end of life, there are quite a few symptoms that we address on patients. And we're just going to briefly go over some of the ways we would address these particular symptoms in a patient at the end of life. Pain. There are many methods to administer medications for pain, especially during hospice or end-of-life care. They can be given orally, sublingually if the patient can tolerate it. Rectal administration can be arranged. Pharmacists are able to compound transdermal routes of delivery for pain medications, injections, infusions. Studies have shown that using pain medicines doesn't necessarily shorten the life of a patient. However, it may make them less alert, or it may make them unresponsive for brief periods of time while they are receiving these pain medicines. Side effects of pain medicines can be jerking. They can make the patient more sleepy and can decrease anxiety if you use other medicines to treat them for these side effects of the opioids, and usually benzodiazepines are used for this. Shortness of breath is a symptom that causes great anxiety with patients and should be treated with oxygen supplementation. This does not increase the length of life, but it does make the patient much more comfortable. Opioids in small doses may help the patient relax, may improve the respiratory status on the patient in that they are not struggling any longer. Also, sedatives to relax the patient and deal with the anxiety, bronchodilators for wheezing, and even steroids for inflammation that might be occurring and causing this. Cool air helps, having a fan in the room. There are a lot of Small things that can be done that help the patient feel better. Alternative medicine such as acupressure and acupuncture, if available, might often help relieve some of these symptoms that the patient has at this point in time. A cough can cause discomfort with pain, increased fatigue, and shortness of breath. Of course, if the patient is on an ACE inhibitor, stop it now. And this may help with the cough, but most of the time it is a complication of the disease process going on with the patient. Using bronchodilators, steroids, opioids will often help relieve this complaint. Fevers can make people achy. Treating fever is of benefit to the patient. It's something easy to do with acetaminophen or ibuprofen, and these can be given orally, rectally, and occasionally transdermally. We're not looking for the cause of the fever to treat it necessarily. On nutrition status, what does the patient want? Do they want enteral feedings? Do they want PEG tubes? If they have these, do they want us to keep feeding them until the end? How do they want this to be conducted? Appetite stimulants such as amphetamines can be tried to stimulate the appetite and help the patient at times. Many family members become quite upset when the patient is no longer able to eat or drink, and this needs to be addressed in their care plan for the family members to be more comfortable as well as the patient. Sedation may help with relief of pain. It will relieve anxiety. And how the patient feels about the end of life may determine some of the treatment methods that are available and can be used for this patient. If the patient is extremely fatigued, we can use Ritalin to help increase their alertness and energy if needed, or to improve even some of the depressive side effects that are going on, because if they are caused by other medications that we need to use, we need to figure out where the benefit would lie in the patient. Delirium is common. It can be caused by the disease affecting the brain itself. It can be caused by the medications we're using to treat the patient. Stopping the offending drugs is the best way to deal with this, and trying to address any imbalances that have developed in the patient. Hallucinations are common at the end of life. My theory is that when the patients are talking to family members that have previously died, they're getting close to joining them. I feel that sometimes they recognize people they know who are helping them to cross over into whatever realm is past life here on earth. And regardless of what your belief system is, this question is going to come up, and it is something you need to think about how it affects you when patients are hallucinating, and also how it affects the family members and how you can try to understand what is going on. If there's hemorrhage that occurs before death because of a tumor that has grown into blood vessels, or radiation therapy that was used to shrink the tumor and relieve symptoms that has now destroyed the blood vessels, we treat it locally with just bandages and pressure. Small things like having dark towels available so that it's not as obvious how much the blood is, remaining calm, and treating anxiety are very important for the patient. What are the ethical issues that we face when we are reaching end of life? One is, what were the patient's wishes? Is nutrition necessary for all patients for all times? Do we want to restart the heart and use cardiopulmonary resuscitation? Does the patient need to be placed on a ventilator, and how much sedation is required to relieve the patient's symptoms? The patient's culture and belief system is very important in influencing these decisions. Finding out during your time of caring for this patient prior to this time of death is important in knowing how they believe and how they think. This influences some of the medications we can use. This influences some of the modalities that are available for this particular patient. Cancer patients kind of have an advantage in that the diagnosis of cancer makes us recognize our own mortality, and we begin to think about these issues and make decisions earlier and give instructions, and this prevents a lot of the anxiety and the confusion that is occurring for people who have not addressed these issues. As patients are dying, a lot of times there's a lot of racket when they breathe. This is caused by the saliva in the back of the throat because their swallowing may be weak or ineffective, and this is called a death rattle. There are some things you can do for this, but the main thing is to reassure those in the room that this is not unusual, that this is not necessarily distress, that the sounds that are occurring are part of the process. In using resuscitation, as I've said many times during this hour, having it discussed ahead of time is important. Do not resuscitate does not mean we do not care. It does not mean we're not going to do anything to help the patient and that we just sort of put them to the side and that's it. Patients need to understand in their families that when we give instructions for end-of-life care or care when we are not able to respond, this care can be changed. We can do resuscitation and then decide to withdraw it. We can decide not to have feedings and then decide to restart those, reinstate them. Decisions do not have to be made one size fits all. Different scenarios can be addressed with different end-of-life measures. A sudden death in a car accident or an injury in a car accident that might result in death might be treated differently than a person who is very old, who has been having debilitating diseases and comorbidities for 10 or 15 years. Those are different situations. Also, the age at which you make decisions is very important. Using ventilation is keeping alive on a machine after the breathing stops. It may or may not help the patient. We need to emphasize that there are times when ventilation is the treatment for the patient, an acute asthmatic attack, a severe pneumonia, after closed head injuries, as opposed to life support measures. And we need to distinguish between the two for the patient and the family. During the final hours, it's important to stay in touch with the patient and the family. Show ways that you are caring for them or that family members can show ways of care for the patient, such as touch, speech, reading with them, often singing with them, massages, rubbing the patient on their arms or their back to make them comfortable. Now, if a patient never liked this when they were alive, they're not going to necessarily appreciate it when they're dying, but if you know the patient, you know what brought them comfort. Some of the physical changes in the final hours of life may be that the skin gets cold and blotchy, the extremities may start turning blue, urine becomes more concentrated and in smaller quantities. The blood pressure will slowly go down, the breathing may become irregular or shallow. 5 Wishes is one of the forms or booklets that I like to use to establish end-of-life directives. It can be ordered through the Aging with Dignity, and it gives several scenarios where different instructions can be given as far as what patients want at the end of their life. Now, part of what I want you to think about as you're going through the rest of your training is How does this affect you? What about the dying patient upsets you? What questions do you have? How you believe what your religious support system is, what your ethical and moral support system is, determines how you approach death for your family as well as for your patients. One of the yardsticks I like to use is, how would I want to be treated if this were me? Or how would I want people to treat my family members when they reach the end of life? This is a good guideline for us all to use as we are going through taking care of patients at the end of their life. If you have any questions or comments, I'd love to respond. My email address is ttonore, T-T-O-N-O-R-E, @umc.edu. And I wish you well as you continue and use the experiences you've had this summer in community health settings to help you become a primary care provider who embraces the entire life of their patients. Thank you.